This is Dr. Cynthia Ma. I'm a professor of medicine at Washington University. It's my pleasure to discuss with you the early stage breast cancer trials at ASCO this year. So this year we have several studies. And one of them, Olympia trial, was presented at the plenary session. It's going to be practice changing. So this study is a phase 3 multi-center randomized placebo-controlled trial that compared adjuvant olaparib for a year versus placebo after patient completed their standard treatment that in patients with germline BRCA1/2 mutations and high-risk HER2-negative breast cancer. And the study showed an absolute improvement of 8.8% in the invasive disease-free survival. And because of that, this study is going to change how we practice in the adjuvant setting for those with BRCA mutation carriers. And then a neoadjuvant talazoparib study was presented, which showed an impressive 45% PCR rate. The trial was presented, the trial name is Neotala. And this raised the possibility whether we could treatment could de-escalate in this population, but more studies are needed. And then the cooperative group EA1131 compared platinum chemotherapy adjuvantly versus capecitabine, which is not the standard for patients who had residual disease following neoadjuvant chemotherapy. Unfortunately, did not meet the primary endpoint, and they found that capecitabine numerically was still better in the 3-year IDFS or not significantly improved with the platinum, even in the basal-like subtype. Therefore, capecitabine remains the standard of care. And then the long-term outcome data for GIPAR-NUVO study was presented. And this trial showed that adding durvalumab to an anthracycline taxane backbone in the triple-negative breast cancer can improve the invasive disease-free survival, distant disease-free survival, and overall survival. However, this is a phase 2 study. Results needs to be validated, and we're waiting for the phase 3 Keynote 522 study results on the EFS data before we can incorporate immunotherapy in this population. And then the outcomes of patients with ultra-low risk 70 gene signature was analyzed in the MINDAC trial. And 1,000 patients were found to have the MammaPrint ultra-low risk category. The data was very interesting. However, since majority of the patients still received endocrine therapy, and majority were clinical low risk, so further validation is needed, especially if we're thinking about downstate, or de-escalate the endocrine therapy, and consider the use of ultra-low in the clinical high-risk population. And for de-escalation of neoadjuvant treatment for HER2-positive disease was presented by the WSG ADAPT HER2-positive hormone receptor negative trial. And the study randomized patients to receive doublets trastuzumab, pertuzumab versus triplets of trastuzumab, pertuzumab, and paclitaxel. In both arms, the PCR rate were high. With the doublets, was about 24% PCR rate. In the triplets was over 70%, which was fairly impressive. The study also showed that as long as the PCR was obtained, the 3-year IDFS were excellent for those patients. So further studies are ongoing to de-escalate further chemotherapy in HER2-positive population. Thank you.